ground, usually whenever we do a lot of our work, it's focusing on two elements. Voice, so knowing that not all voices are heard, knowing that some communities are often left out, whether it's or they don't necessarily attend, or in other instances where we meet with different policymakers in Geneva, in New York, and we then find out there's a knowledge gap in that they're not always aware of what happens on the ground. And then the aspect of visibility, to make sure even where those communities are not seen or heard, that there is a way that they can be seen and heard in those policy-making spaces. And so we're just highlighting in this context, especially Africa, there are often a lot of issues that are considered taboo and cultural. And so when we think about the health outcomes in the country, we know that there are certain barriers to, for instance, ensuring that there is a comprehensive HIV response, but also that there are some experiences that impact the ability to access health services that can be structural. Just highlighting what some of this work comes from. An example, the SADC Gender Protocol, Ministry of Health and Wellness Technical Working Groups, the Universal Health Coverage Platform, the African Commission on Human and People's Rights, the International Commission on Population Development, ICPD, that was a wrong abbreviation, and then also the African Peer Review Mechanism, which was through the Botswana Council of NGOs process. I think it was 2020. And so I think for us is to make sure there are gaps in terms of at local municipal level and national government level. And then also even in civil society, where we know people who work on certain issues, for instance, those who work on climate issues, don't always get to national development processes. Similarly, those who work on health issues at a community health perspective, they don't necessarily access, for instance, the African Commission on Human and People's Rights. And so for us, in addressing this gap, is in sort of creating a forum like this to be able to share some of these insights, but then also, what are the opportunities for yourselves to be able to access these spaces in a very practical way. And so we're really anchored on leaving no one behind. And so this is why today, yes, although it's focused on ensuring good health and well-being, SDG 3, we're acknowledging there are social determinants in the form of gender-based violence, but also primary healthcare. Because we know in instances where, for example, there is sexual violence and a case needs to be reported or someone comes to a health facility, then more often than not, we use police to come and make sure they are able to collect evidence and document some of the experiences, or even when there's a need to get someone on a PEP, post-exposure prophylaxis, to make sure we're able to link with other services. And I know in other locations where we have held workshops, usually they even turn to dikgosi or to link with social workers, the family. And so a lot of these issues usually is because of community and with community. So ensuring representation, acknowledging sometimes language is a gap, knowing what are the ethnic minorities and indigenous people, and then trying to make sure that there's an element of inclusion. And so we'll be showcasing, I think, at least 2 documentaries. If time allows, we could showcase the third one, where we recognized what sometimes people maybe don't have the confidence to present before parliamentarians or elected political representatives at a council level, and that they found it easier to be able to share that in a visual documentation. In other instances, we usually have some form of performing art in the form of poetry and so forth. And so this is just sort of giving some of the locations more recently where we had done some of the work. Again, mentioning community knowledge, donating sanitary pads, and then making sure that we're linking these practical, tangible, and meaningful activities with policy. So I think in May, we actually facilitated a 2-day dialogue with parliamentarians, particularly mostly from the Parliamentary Caucus on Women, and it was a UNFPA facilitated dialogue on key populations and SRHR. And so for us, looking at the journey, 2015, when we just focus on community, and then we fast forward, after engaging council members, after engaging Dukosi in different locations, that for us was a mark of success and progress to say we're now able to discuss issues of sex workers and LGBTI with elected parliamentarians. And so for us, that was something that says for at least we can be able to document progress and the ability to have dialogue. Some of the main structural challenges is around, obviously, politics. We acknowledge what sometimes the experiences of these communities can be used, particularly around, garnering elections. This is obviously more prominent in other regions such as West Africa and East Africa. But then also, sometimes we say these communities don't exist. We say they're not there. Meanwhile, at a grassroots level, we know how we deal with so many issues. And then specifically looking at the fact that climate justice is one of the biggest thematic issues, and that in Botswana, we don't necessarily, incorporate some of those conversations along with some of the issues around reproductive justice. Also just mentioning the issues around exclusion, marginalization, knowing stigma and discrimination, because either people don't understand, or also maybe we have some incidents where people then speak about religion or culture and not being able to assist community members. We're also acknowledging Botswana is the fourth most unequal country in the world. And that it is the first. I think when we came into the pandemic, it was the second after South Africa. But amidst the pandemic, as we had seen with so many media reports, Botswana then ended up as the first with reported rape incidents. And we know that there's a significant percentage that isn't reported because of the issues that accompany trying to report and seek legal redress. And then also we're just noting there are some gaps in laws. We're acknowledging yes, there is progress with some policies being implemented, or for instance, with strategic litigation around same-sex intimacy, but we are still quite behind, knowing there are child marriages in some ethnic and rural communities, and then also that bodily autonomy and integrity, the ability to exercise choice, isn't always really allowable because of issues that I mentioned above. And then we must also acknowledge a lot of these issues are as a result of colonial legacies, where we have inherited laws on independence, and in adopting the Westminster parliamentary mode of governance. And we're acknowledging some of these laws are quite outdated and they don't necessarily speak to the lived experiences. And we're acknowledging in our journey, there's a lot of need for healing. There's a need for transformation. We're recognizing a lot of perpetrators also have their own stories of injustice. And so we're really using an intersectional lens to look at some of the issues that we're dealing with. We're also acknowledging yes, we're going to have a workshop, and that we would have changed the perceptions around LGBT, for instance, at the end of that workshop. We're acknowledging it won't be as clear. We're acknowledging sometimes there'll be those who will be opposing, and sometimes there'll be those who will sit and say, you know what, let there be diversity and inclusion, and there are those who can be even more accepting and allies to different movements. And we're just acknowledging it can't always be as we perceive, that things can go wrong, but as long as we're still working towards social justice. Then another element is also recognizing sometimes solidarity. We've found where former leaders are very affirmative of some of the issues, whether it's abortion or whether it's LGBTI issues. And often we found they are that progressive as a result of no longer being in public office. And so these are just where the dynamics where we're sitting and saying, how can we have that solidarity that isn't performative, that is based or anchored on Ubuntu or Seto Kanabotu, and that it can really alleviate inequities. And then also acknowledging there are different value systems. Sometimes it's the aspect of time. Sometimes it's also because maybe the funding isn't available. And then also we're acknowledging the elements of care, where we know women tend to carry the burden of care. So go tlhokomela bana ko lapeng, and in many instances then they have to find means or ways to make sure the family can be well fed. And these are just some of the structural aspects that we're noting. And then we've also said, there's a need for a more holistic approach. HIV is not just about a syringe. It's about ensuring that someone is able to have a nutritious meal, that their medicines can be in a safe location, with room temperature, so that it doesn't compromise the quality of that medication when they need it. So it means that we're speaking to aspects of food security. We're speaking to aspects of being able to have home shelter. And then also speaking to, some of the social aspects in terms of discrimination that comes with having to take certain medicines or treatment. And then also, we're acknowledging we have to integrate. We cannot do our work without integrating aspects of disability, youth, especially because we are youth-led, and then also some of these regional engagements that I've mentioned for learning and sharing some of these lessons learned. That being said, I'm just going to briefly touch on this concept, universal health coverage, and why it's important as a foundation for the topic, primary health. So universal health coverage really then speaks to making sure regardless of whether is able to access all services that they need, health services that they need at the least cost, with the least inconvenience, and in ensuring that those services can be shared, that they're standard. And we obviously know that that is not the case at the moment. We know infrastructure is not the same, but sometimes they don't necessarily allow access. One example that we can give is Chukumuchu, for instance. Chukumuchu is a good, I think, just under 100 kilometers from Muhembo, Muhembo Shakawe, if I'm not mistaken. And the road is so bad that there is no public transport anymore. And so you find now when someone has to access a health post, which is not in Chukumuchu, but the closest facility would be in Shakawe or Muhembo, that means that someone has to find a way, either to wait for a nurse to access services. And so you find a nurse can rotate around those the villages or that location in that district, and it takes them 7 days to access one village. Or we had the worst case where a woman went into or went through her pregnancy full term, so that is the full 9 months, and giving birth without ever having seen a nurse. This is in 2022, one of the leading democracies in Africa. And so we are saying that it is not acceptable, that at least we must be ambitious when we're saying we want to achieve the Sustainable Development Goals. We want to make sure that there's universal health coverage for everyone, including migrants, including those individuals who don't have income, including those individuals who might be engaged in sex work, including the elderly. And so this is just at least speaking to the broader picture. For a universal health coverage is the bigger aspiration that we want to achieve. And then maybe just to highlight, when we speak about primary healthcare, obviously that's from a practical perspective. Today, we do have primary healthcare, but it's not enough. And so how do we address some of these gaps whilst trying to work towards this bigger vision of universal health coverage? And so just highlighting the quote, "Never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it is the only thing that ever has." And so we're hoping that even, that we can be able to find some solutions and be able to document that and move forward with it as a collective. And so this toolkit, I will share this presentation, is something that's very easy for you to have with your constituents, or even just for your own knowledge, just to make sure what is happening at a global level, especially because Botswana was one of the signatories of the political Declaration to Universal Health Coverage in 2019 at the United Nations General Assembly. Why is it important? It's important because when there is a challenge at a health post or at a clinic or at a hospital, we can sit and say, but the country has committed not just the budget as per the Minister of Finance budget every March or February or every government financial year, but that there is an international commitment that the government has said, we will fulfill this aspiration or this commitment, and we will make sure we are able to serve all our residents and citizens. And so this helps us to sit and say, yeah, how do we measure progress since 2019? Is it actually helpful or it's not? And that opens up other questions to say, okay, fine, why are people not accessing health? Is it because they're not good enough? So that's infrastructure. Is it because culturally, people genuinely go and seek services when they need them the most or when it's very late? Or something is wrong, and I wait up until I really can't go to work or I really can't do anything. So is it a social behavioral issue? Or is it a case where maybe some people cannot take leave or they're not allowed to take leave because maybe it takes a long time and there's a long line in some places? And so we're just really speaking about promoting health, but acknowledging, Harari universal access. It means we're able to address all the needs and make sure when there is a situation like the pandemic, we don't resort to some of the issues that happened. For instance, the psychology department was closed, Go Marina, which was the only facility that was available in the greater Gaborone area. For psychosocial services. So that meant that people had to go to the psychiatry department, which then also had its own, resident and non-resident patients. So that means they were stretched. Or, for instance, when SRHR services were stopped because they deemed it not emergency and because the health facilities were stretched. So that meant newborns or, maternal needs were not able to be addressed during or at the height of the lockdown. So as I had mentioned, it's just an aspiration towards making sure that all health services, when they're needed, that they're of good quality and that there isn't any suffering or any hardship. So we talk about equity, we talk about access, we talk about affordability. And I think this just highlights a lot of the different commitments that had been made, but also the organizations that are working towards it, such as the World Health Organization, at least at a global level, knowing that there are obviously those that are working under the Global Fund, which I think there are quite a few in the audience. And then obviously the commitments, the overarching one being SDG 3 from the Sustainable Development Goals, but then also knowing there are some countries which are financing a lot of countries' health systems. For instance, the US government through PEPFAR or through USAID. And then you're finding that there's also other groups, with the G20, such as Japan, who also contribute to the Global Fund and so forth. So there's quite a number. And so I think the G7 and the G20 is just acknowledging, the most powerful nations in the world that obviously finance quite a bit on health. And then, as I mentioned, the high-level meeting on universal health coverage, where the political declaration was committed to. But then at the Africa level, 2001, there was the Abuja Declaration, which was specific to the 3 diseases, HIV, malaria, and TB. Why is this important? It's important because some of these issues, our ministers of health or even our permanent secretaries not only go to the meetings that track this progress and report on Botswana, but that they use this to, for instance, contribute towards, as an example, the National Strategic Framework on HIV, the 3rd iteration, or, for instance, with Vision 2036, or with the current redesign or the development of the upcoming National Development Plan. So all of these are quite important. And I think, for us as Success Capital, how do we make sure our grassroots organizations can be able to contribute towards this larger picture? And so that then obviously speaks to the role of civil society in making some of these important. So as mentioned, making sure that we're leaving no one behind. So making sure that different community members are included, making sure that investments in health can be significant, that Botswana are not impacted negatively. So knowing that sometimes maybe for someone to access service, they have to spend 100 pula in transport costs because it's in a different location. Just to be able to get, for instance, a referral screening. But then maybe whatever appointment that was set up, there wasn't enough time for it, and so the person had to go back and come back the next day. And then also to make sure that, how do we engage meaningfully, and then how do we support health workers? Because in many instances, I think we've heard time and again where, health workers are not always resourced, that there's commodity shortages, and that they have to make a plan because in some instances, it's literally life or death. And so I think this is just highlighting what there are various elements that obviously contribute towards health when we speak about health spending. So it's not just the global commitments, but also that there are laws, that there's specific ways that they should be planning, for instance, for the government fiscus, and even in terms of how some of the allocations go to local government, which then in turn obviously then does impact health referral services. And then also with the budgeting processes and making sure that they can be monitoring and evaluation to assess, are we really investing in the right priorities? And then obviously making sure we're able to mobilize communities and really educate. And I think we've seen examples of this in the COVID-19 response. And so, yeah, I think this just highlights, in terms of how the toolkit can be able to assist and help. We had consultations on UHC in Francistown and in other locations just to make sure we're inclusive in that process. And so with this primary health coverage exercise, we made sure we're going to other locations that we haven't accessed, such as Khanzi and Gumar. And so the toolkit is really just there for us to make sure that we're learning and that we're collaborating with others and that we can share some of these best practices. And so I think, when we speak about, some of these realities, and we're now sort of honing down, one of the biggest issues that have emerged over the last 2 to 3 years because of the narrow policy landscape is SRHR. And so this is, basically just as a definition, a state of physical, emotional, mental, and social well-being in relation to sexuality, and not merely just because khakelwale does not mean I still don't have health needs. So it's really about making sure we're really addressing the issues of someone's health and well-being. And then obviously, as I mentioned, SDG 3, and then gender equality, knowing the gender disparities, sometimes some of the SRHR needs for men are not the same as for women or for LGBT individuals. And just noting it's in line with Botswana's human development and social development pillar. As I'd mentioned, the Abuja Declaration had a requirement for governments must spend at least 15% of their expenditure on health. And as you can see, Botswana, 2001, was one of the lowest countries in the bottom 10, I think, if I'm not mistaken, on the left. And then by 2011, Botswana then even went lower, much, much lower. So that already just highlights we are not doing enough to make sure we're investing in our health systems. And I think one of the other things, to mention is that the fact that there's been success in our HIV progression story, in one, having the highest disease burden, but also being able to really address some of the key issues is really quite telling in the fact that we're not able to actually spend as committed. Because if we did, then maybe we'd be in a much better position, even when it came to the pandemic, as we had done in the initial days. And so that also just highlights the spending levels in comparison to other countries. And I think it's really quite telling, especially because we're acknowledging Botswana doesn't have a high population. And when we look at from a SADC perspective, Botswana in between 2001 and 2018 had been relatively there, a little bit better than some of the other countries, but obviously not necessarily the best. And it wasn't obviously meeting the Abuja Declaration. Yeah, 15%. So I think it's a common thread in Africa. How do we make sure that we're able to improve and show that Botswana can be one of the leading countries in the broader health response and not just in HIV. I think it's quite important for us to note globally there have been 12 million unsafe abortions that were carried out, of which between girls of the ages of 15 and 19, and that just over 700,000 were under the age of 15 years old in developing countries. So that is the global south. And then there's a report that a further 5.6 million were actually unsafe abortions, so unintended for girls in that same age group, and that 3.9 were unsafe. So in other words, abortion is there, it exists, 12 million girls have had it, but if we're to look at a specific age group, ages between 15 and 19, 3.9 million of them were unsafe. So that means there were backdoor because of maybe it not being allowed. In Botswana's case, it's allowed only under certain conditions. and that, you know, almost 70%, which is higher than the global average at 25%, are in the global south. Unsafe abortion actually costs a lot of health systems $6.9 billion US. And so that already says, even though we're sitting and saying safe abortion is not allowed, as in someone is not able to go to a facility and say, I would like an abortion as one of the primary healthcare package services, that means that it actually costs us, because with whatever it is that they went and did in the, you know, backdoor abortion, because some people take certain liquids, others have certain instruments that are inserted to terminate, you find that then there are complications. And so when there are complications, they have to turn to a health facility. And so in turning to that health facility, it obviously costs the state fiscus. Africa registers less than 1% in terms of public health spending in comparison to 3% globally in issues of mental health. So this actually shows the extent at which mental health is often neglected, as ideally which it should be part of primary health care. 1 in 10 girls do not go to school because of period poverty. We actually started our sanitary pad donation drive because of this realization. We had done a study in Mogane, which is a small village close to Mahalape, about 80 kilometers away. And we found that, or were informed that you are finding people, they don't meet the criteria for Mabui. And maybe that just means maybe or, you know, just earns a little bit above. It does not necessarily mean it's not an impoverished household. It does not necessarily mean that they can afford something as basic as sanitary pads. And so we then realized there's a need to address this gap, and not just address this gap now practically, but also work towards changing the commitments to make sure everyone can receive sanitary pads. Botswana, Egypt, and Morocco are the only countries that have not signed or ratified the Maputo Protocol. The Maputo Protocol is the African Charter on Human and People's Rights specific to African women. So it has signed the SADC Gender Protocol after years of lobbying, but then it has not signed that of the Maputo Protocol. Why? I will state just now. Similarly, Botswana, Eritrea, Morocco, and Somalia, when you look at the conditions of those countries, economically, politically, or even with conflict in terms of militarization and some of the issues that some of those countries face, how is it possible that Botswana will be on the same list as those countries? So just mentioning what they have not signed the African Youth Charter. And so the reason behind this is because socioeconomic rights are not justiciable. So in the country, even though, yes, at the African Commission, the government said they do respect economic rights, social rights, and cultural rights. But we know how to back socioeconomic rights, and especially looking at neighboring South Africa. South Africa, in its constitutional democracy, can acknowledge and say, the right to water, the right to health is guaranteed in our constitution, and we must be able to work towards it as a government. And so in the checks and balances, when people take the South African government to court, for instance, I'll give one example. I think it's Subramuni, when they were talking about the right to water. You know, at a high court level, the high court went and said, no, a family of 4 should have X amount of kiloliters of water per month. You cannot just go and disconnect, because the right to water should be guaranteed in our constitution. And then the Supreme Court of Appeal came and said, no, but a family of 4 should have Y amount of kiloliters of water within peri-urban areas, and in urban areas, it should be X or Z kiloliters of water. And then the Constitutional Court will come and say, we're acknowledging the government does not have enough resources, but there's a concept called progressive realization, which means that the government can work towards making sure there's infrastructure, there's policy, there's service delivery to guarantee the right to water. And so when you look at Botswana's context, when we turn to the courts, a lot of these socioeconomic rights are obviously not allowed. And so this is for us to sit and say, how can we practically achieve this? So we are sitting and saying, right, let us have aspirations such as universal health coverage, because it will allow us to speak to the social determinants. It will allow us to speak to structural issues and not just basic healthcare. And how or what is the entry point for speaking about universal health coverage is where Botswana is right now in primary healthcare, in saying, this is our assessment, primary healthcare is not enough, and that we must be able to address and put in the right instruments, such as SRHR, such as mental health, and making sure that all these global political commitments can get us to that right to water, can get us to that right to food security, to shelter, and work, and so forth. So we're trying to be as strategic as possible in making sure we're seeing, yes, in the courts it's not always successful, or through laws it's not always successful. Let us see how we can use health as an entry point in addressing some of these issues, in making sure that we're able to address the needs of our communities. And then in some of our research work, we found that illicit financial flows actually cost Botswana $856 million. So that is almost 9 billion, or if not more, at current exchange rates, 9 billion pula, because of illicit financial flows. Illicit financial flows are white-collar crimes. They are the way that multinationals take back their capital, or not pay tax, or find loopholes such as transfer prices, or such as management fees, and make sure we are denied the kind of tax revenue that is needed to support our infrastructure. And this is not unique, because when we look at the early days since independence, Botswana, especially with the public-private partnership such as Botswana, or between government and De Beers, we have seen how that mineral revenue, unlike many other African countries, for instance, even now, when you look at the Congo, or even the Central African Republic, where there's conflict because of corporate interests, we can see Botswana developed largely because of that economic growth, and because there were significant investments in infrastructure, in roads, in health, in education, and some of these more basic issues around development. And so we're sitting and saying, in as much as we want to address universal health coverage, we want to address SRHR, we want to address mental health, we must look at this big picture properly. And we can see there is people who are not paying taxes appropriately. There are corporates that are taking advantage of Botswana's financial systems, and they're not making sure that the country is able to generate enough revenue to address the needs of all its citizens and residents. And then, we looked at the Auditor General reports, and we saw there are infrastructure shortcomings, pharmaceutical challenges in terms of commodities. I think initially we heard about condoms, being missing, and at some point paracetamol not being there, and so many other sort of commodities that are not available. Issues around water dispensers for infants was one of the things that were highlighted. So this then directly speaks to SRHR. It directly speaks to primary healthcare, because when we access there's a primary healthcare package, it means that whatever services that are needed, whether it's a health post or a clinic, that an individual is able to access those services when they are needed. So now it's obviously not helpful, the current system, where someone is trying to get a service and is then referred to another facility that might be a taxi ride away, or that might be in another location. And so that means that for them to go make an appointment, they have to physically go there and then come back a few months later to get that, instead of being helped and assisted in that facility as and when the need was or arises. And so this is just sort of giving that highlight. When you look at, for instance, the March 2021 report that was given amidst the pandemic, you then see significant amounts were spent. So there was an over expenditure of 24 million, if you look at the bottom right, which is 30% over what the Minister of Finance had projected will be spent. And when you look at, what kind of, where are they spending in, you can see there's a large portion that is being spent on clinical services. So obviously that is, provisions, commodities, equipment, and so forth. And I'm assuming that, staff costs are there as well. and then we must sit down and really ask ourselves, okay, is our community health, providers, included in there? Because we know that sometimes when there's a campaign, for instance, around, anti-tobacco or anti-alcohol, there are volunteers that are engaged under the ministry, or there are civil society organizations that are engaged. And so this allows for us to then really see what are the issues, if they're spending 6.2 billion on clinical services, then how come clinical services are not able to address all the needs for a population of 2.3 million, for example? And so I think this was just giving the statistics and the realities. Botswana, women's unemployment rate is 48.7% in comparison to young people who, I think when you consider those who are discouraged, who are no longer applying, the World Bank had actually pegged that just above 32%. And we're acknowledging that Botswana is a better country than many others, where we see literacy is very, very high. And it's good in the context of, women and girls being allowed to go to school, unlike other contexts where literacy is a little bit lower. But we're seeing where there's HIV prevalence or new incidents among young people, new incidences among sex workers, of which a majority happen to be women, amongst LGBTI community members. And so this is, quite important for us to just contextualize in the context of Botswana. And then 60% of women have experienced some form of gender-based violence in their lifetime. And so that should be telling, because then that means in our households, in our homes, in our work environments, with our clients, with our partners, we must acknowledge that there is GBV and that there's a need to be able to address that. I think his recommendations that we had made, we just said, improved multi-sectoral and segmented coordination. We know, gender, recently we found out about the Gender Commission, but also under this gender machinery, at a municipal level, where there's a gender committee, or there's a child protection network, or there are these, HIV response partnerships in the form of, those supported by NAPA or those supported by PEPFAR, under DREAMS or FHI and so forth. And then that, there's a need for data, obviously disaggregated data. Or how do we ensure that in an evidence based environment, policy making, how do we ensure that there's inclusion? How do we ensure that we're able to access BIDPA, the Attorney General Office, Auditor General Office, Statistics Botswana, and the Population Development Unit in the Ministry of Finance? Because all of these don't necessarily work with CSOs, and if they do work with CSOs, they don't work with the same CSOs. So how do we make sure there's a bit more of a cohesive strategy towards fulfilling SDG 3? And so integrating UHC in public health policy and programming, and making sure we can report on this. And then, we need to support research. We need to support, these emerging issues that we are not always capturing very well, that we're seeing in media, and there's no change. If you look at, the public discourse and what is being reported, especially around GBV, especially around health challenges, 2019, 2015 is almost the same as now. And so something has to shift and change. And this is one of the reasons why we felt like, we need to come and, let's us have this conversation as different stakeholders, and that this is quite important. That being said, thank you so much. There's a link that has got quite a lot of insights and resources that we have. Please do just take note of it, so that when you can be able to access a computer, you can be able to access some of these resources and easily use it in your own advocacy. Thank you so much. I really tried shortening the time, and I hope that